Welcome to tonight's webinar, Silicosis, What GPs Need to Know. We are delighted to have you here. My name is Sue Clute from the iMed marketing team. Before we begin, we would like to acknowledge and pay our respects to the traditional custodians of the land on which we meet, past, present and emerging. We recognise their deep connection to culture and country and appreciate their ongoing care and custodianship of land, sea and community. iMed Radiology takes pride in being Australia's preferred imaging provider, responsible for 1 in 5 diagnostic scans. As we continue to grow, we have improved our support for delivering high-quality patient care. For instance, did you know that using an electronic referral results in patients booking their iMed appointments 4 times faster compared to printed requests? This means quicker follow-up and better healthcare outcomes. Visit our website at i-med.com.au to learn more about the advantages of e-referral. Tonight, we are fortunate to have Professor Catherine Jones, an iMed radiologist, presenting on imaging and dust diseases, with a particular focus on silicosis. Professor Jones will discuss the current evidence and best practices in this field. Facilitating tonight's session is Dr. Philip Pearlstein. We sincerely appreciate Dr. Pearlstein and Professor Jones for taking time out of their busy schedules to prepare and present for us. Before we begin, I'd like to address a few housekeeping matters. This educational event is being recorded and will be available on our website, i-med.com.au, alongside our other educational webinar recordings. You will receive a certificate of attendance via email, and if eligible, CPD hours will be logged on your behalf. Lastly, we value your feedback as it helps us improve our educational efforts. Please stay on the line at the end of the webinar to provide us with your thoughts. Now, without further delay, I would like to formally introduce tonight's facilitator, Dr. Philip Pearlstein. For those who frequently attend our webinars, Dr. Pearlstein actually needs no introduction. He is a valued member of our Education Committee with experience in tutoring undergraduate students at Monash University's Department of General Practice and examining candidates for the Postgraduate Fellowship of the RACGP. I will now hand over to you. Thanks, Dr. Pearlstein.
Thanks very much, Sue, and good evening, everybody, and welcome to this iMed webinar focusing on what we as GPs need to know about silicosis. It's great to see so many of my colleagues attending. As you're aware, over about 500,000 workers are currently exposed to harmful silica dust, making it crucial for GPs to understand the latest screening, diagnosis and management best practices of silicosis. iMed is very fortunate to have a world-renowned expert as part of their team, as Sue mentioned, and Professor Catherine Jones will lead us in this discussion. Professor Jones holds a subspecialty radiology qualification in cardiothoracic imaging and practices general radiology with a strong interest in chest imaging, particularly in dust-exposed workers. She advises several governments and clinical task forces on appropriate imaging in dust disease and is Associate Professor of the, of the School of Public and Preventive Health at Monash University. Catherine obtained her B-Reader qualification from the National Institute of Occupational Safety and Health from the US. This qualification recognises her ability in thoracic radiology in the setting of pneumoconiosis detection. She is an adjunct professor at the University of Sydney, curating content for medical students and clinicians. She works with medical AI companies to develop clinically useful AI tools for medical imaging interpretation, workflow and education of doctors and other healthcare professionals. We're very fortunate to have Catherine taking us through this subject. Please feel free to ask any questions during the presentation by using the blue hand icon to enter your question. I'll monitor these questions during the presentation and will attempt to have as many as possible answered at the end of the presentation. There'll also be several poll questions during the presentation to make sure we're all still awake. So thank you very much, Catherine. Over to you.
Thank you, Phil. So thank you everybody for attending this evening. I know that it's the witching hour, everyone's busy in the evening. There's a lot to get through tonight, so please do put any questions into the chat and we will do our best at the end to answer them. Here's my qualifications and disclosures slide. So we might as well jump straight into it. When we talk about occupational lung, what exactly do we mean? Well, we have lots of types of occupational lung disease, and probably the most common one is asthma. But we also know that there's an increasing awareness around the world, particularly here in Australia, where we are leading the way really on screening and diagnosis of pneumoconiosis. And this includes silicosis, which I'll talk about today, but also in our mining community, other types of mine dust disease. As well as that, it's important to remember that asbestos-related diseases, including asbestosis and mesothelioma, remain the most commonly diagnosed significant occupational disease across Australia. I won't really talk about that too much today. We also know that patients who have dust exposure are associated with much higher prevalences of sarcoidosis, TB, and rheumatoid arthritis, and other connective tissue disorders. So that's important to bear in mind as well. And last but certainly not least, these patients are at increased risk of developing lung cancer and mesothelioma. So that needs to be at the background of everything that we do. So why is dust disease a problem? Well, we have a limited amount of defense when we inhale dust. And usually, of course, we try to exhale the dust. The problem when you work in an occupational environment where the concentrations of dust are very high is that these normal defense mechanisms become overwhelmed, particularly when this is, long shifts, day in and day out, for weeks and months, and eventually years and decades. We know that occupational exposure is what is required to be at high risk. Even with, spouses of people who work, who may be exposed to dust, either from the clothing, from the worker, or from environments like the car, they are at slightly increased risk. But it really is an occupational exposure that we talk about as being the high-risk activity. So what's the role of the GP in all of this? Well, we'll talk about this throughout the rest of the talk as well, but just a few points at the beginning. Patients who come to you with either symptoms or concerns around their dust exposure, they may not be part of mandatory screening programs. And this is particularly the case if they are no longer working in the industry. And this can be because they've retired at retirement age or because they've left the industry and gone into a different type of work role. But it's also for people who are casual workers and who aren't registered as, workers in the industry, or if they work in an industry where they are exposed to dust, which has not yet become subject to mandatory screening programs. Now, of course, when you see somebody who comes in with symptoms, you need to factor in all of the usual decision-making about whether imaging is suitable and whether perhaps you need to do any lung function testing. It's also important to be aware of the compensation pathways that may be available to patients who have a diagnosis. And of course, it's important to be aware of the appropriate times to refer either onto a respiratory physician or an occupational medicine physician. So the next obvious question is, well, what is the role of radiology in all of this? Well, radiology is a pretty key part of the diagnosis. And it's important to remember that we should always be doing this in conjunction with the occupational history, because without an occupational history, it's very difficult to make a diagnosis of occupational lung disease. We should also, if possible, have information about what the respiratory function testing results are like, and really as well if the patient is a smoker. Radiology is really important for monitoring of disease if it's diagnosed, and of course, if there is a need to do a biopsy, it is often done under image guidance. So let's move on and talk about silicosis itself. It's often been referred to as a disease of antiquity. It's been found in Egyptian mummies because for as long as humans have been living on this planet, we've been trying to dig it up. And silica is in every hard rock that is out there, particularly marble, granite, but also sandstone and other stones like that. Now, we know that natural stone has a variable amount of silica within it, varying between sort of 5 and perhaps 30% of silica. And people who have been involved in quarrying, tunneling, sandblasting have certainly been exposed to high levels of silica dust for many decades, or in the case of the Egyptian mummies, several millennia. We also know that some of the more recent industries, such as glass making, grinding, and using foundries, has also led to increased concentrations of silica dust. However, it's really been in the last 15 years or so that we have new artificial products which have extremely high levels of silica, and that has prompted in the last 5 years an increased awareness of the dangers of silica. So we'll get onto that, but first I just want to talk about what the radiology of silicosis looks like, because this is something that we are very familiar with in our industry, but it's very, not something that GPs would typically know a lot about. But there's 4 types of silica that we can identify on radiology, and that goes through the acute, the simple, the complicated, and the accelerated. And I'm going to show some examples of what that means in the coming slides. Very important to remember that there is often significant overlap between pure silicosis and other types of dust disease, because a lot of our patients work between different companies and they're exposed to different things. And even if they are working in the one place doing, for example, tunneling or quarrying, they may be exposed to more than one type of dust within the rock that they are using. So acute silicosis is something which, until recent times in the last few years, had been considered to be extremely rare. It was found predominantly in patients who had been very, very heavily exposed to respirable silica. And respirable silica simply means that the silica has been ground down into a dust size, like the particle size is small enough to be inhaled and slightly too big to be absorbed by macrophages. So something around the 5 micron diameter. And unfortunately, when it was popular to sandblast genes to make them look distressed, to be sold, unfortunately, a lot of those workers in certain countries developed severe acute silicosis, and there were many reports of those workers needing lung transplants or dying. We also know, unfortunately, that manufactured stone, which is also called engineered stone or artificial stone, is the same type of acute silicosis response in many workers. And acute silicosis is defined as you develop symptoms within 3 years, and it has traditionally had a very poor prognosis. We do wonder, with early evidence, that whole lung lavage may help workers who are identified in the acute silicotic stage. I'll talk about that a little bit later. Here is an example of a CT chest of a patient who's only 31. He had had less than 2 years of exposure to dust. He claimed to be asymptomatic, although on pressing he did admit to being short of breath after walking up flights of stairs. And his chest CT shows this ill-defined greyish kind of look to the lungs. Now the lungs should normally look pretty black because they should be full of air. And when you've got that haziness over the lungs, it indicates that there is an exudative response by the lungs to try to get rid of whatever's in there. And this is a pretty bad sign in somebody who's that young, who's been exposed to the dust for a short period of time. Now, this particular worker was removed from the workplace, and after 11 months of no longer being exposed to the dust, he has the image on the right, which is clearly looking blacker, which means that there's more air in there and not as much silica and fluid being exuded by the lungs to try to get rid of it. His lung function test significantly improved, and his exercise tolerance as well. Simple silicosis is by far what we would have considered up until 5 years ago the most common form of silicosis that we would see. It's characterized by the small particles of silica that weren't able to be expelled from the lungs, forming small little nodules less than about 5 millimeters in size that we can see on the CT. And that's the body's attempt to wall off the silica with a surrounding granulomatous response. The nodules haven't started to form together to form, masses that we call progressive massive fibrosis. And over time, in an attempt to absorb these into the lymphatics, the nodules can get drawn towards the periphery of the lungs. We do know that there is an increased association with scleroderma, with rheumatoid arthritis, and with lupus. And most of these patients would claim to be asymptomatic, and they don't suffer from significant functional impairment at this point. Here is an example of a 46-year-old man who had been a stonemason for 19 years. And this is the sort of story that we would occasionally see in preceding times. Stonemason, no exposure to artificial stone. It takes at least 10 to 15 years of exposure at the lower levels of dust to be at risk of developing this sort of picture. And this CT slice shows lots of tiny little nodules in the central parts of the lungs. Don't expect you to understand what a normal one would look like, because this is a pretty subtle example, but there are tons and tons of little nodules there. When we look at this in real time, going through it in different planes, you can see that there is very much a certain distribution of nodularity, which points to this being silicosis. There's not a lot going on the fissures in this particular person, but when we look at it from the front in the coronal plane, you can see more clearly that all of those nodules are there in the top half of the lungs. And this is almost definitely, even without the occupational history, going to be silicosis, because the features are so typical of silicosis. We do sometimes get some changes in the nodes as well, which can be increased in density, and that's a response to the silica being absorbed into the lymphatics. Here's another example of a man who's 44. He's had 24 years of exposure doing what's called dry cutting, which is where, as the drill goes through the stone, there's no water running over the top of it to take the dust away. And so the plumes of dust that are exposed in the air massively increases the concentration of dust to be inhaled. This person also shows lots of nodules in the upper zones, and we can see that they aren't starting to distort the lungs. There's lots of enlarged nodes centrally in the chest with those little white dots that look like calcification. It's the silica. And we've hit the first poll question. So, first poll question: diagnosed with simple silicosis, the patient may be asymptomatic. Is this true or is this false? And I'll give you about 20 seconds to have a think about that and give an answer. Okay, we might move on. Of course, the answer is that is true. The patient may be asymptomatic. They are unlikely to have significant symptoms or functional impairment when they still have simple silicosis. Let's move on and talk about the complicated silicosis. And complicated silicosis is when the nodules that we saw before in simple cases start to move together and to form masses and conglomerates. They need to be at least 1 centimetre in diameter for us to be calling that progressive massive fibrosis, or PMF. The trouble with these is twofold. It can be very difficult to distinguish this from lung cancer, because people who are exposed to dust are also at risk of developing primary lung cancer. They may also be hot on PET scans, so that doesn't help distinguish them either. And over time, the distortion of the lungs leads to a rapidly progressive decline in lung function. And this is really the type of silicosis which leads to people being on home oxygen and not being able to function well. Here is an example of a 56-year-old man, also a stonemason, who has innumerable nodules through the upper zones of the lungs. And you can see on the coronal view in the middle of the page there that these are now starting to form, sheets and then masses of nodules forming together. This is a clear case of PMF, and the image on the right shows multiple nodules which are enlarged and also appear calcified. So this man has many, many features of complicated silicosis. Now, accelerated silicosis is really what we've been worried about in the last 5 years, because this is features of the complex disease, but it's appearing way, way quicker than the 10 to 15 years that we would expect in the natural stone exposed workers. And this is really, we think, because of the high rate of concentration of dust and the high percentage of silica within manufactured stone. We also are not clear whether some of the resins that bind the stone together may in fact themselves be contributing to the silicosis. But you can see the images here. We've got a worker using a saw to cut out what's probably a sink in the top of the bench top. If there's no water running over the top of that drill, then we end up with a lot of dust in the air. Because these workers are exposed to such high levels of dust, we end up with a mix of both the acute findings from these acute silicosis as well as the more chronic findings. And so we're starting to get younger and younger patients presenting. Here's a 27-year-old who had been exposed to the dust in the benchtop industry for about 7 years. And he has a number of small nodules throughout his lungs. When we look at it again from the coronal perspective, we can see many enlarged nodes on the image on the left. And on the image on the right, we can see tiny little dots all the way through the lungs that really shouldn't be there. So this is a clear case of silicosis. Here is another man who is 29. He's also got 7 years of dust exposure. And we can see even from this initial slice that he has quite significant nodularity starting to form scars throughout the lungs. And this is a bad sign even on just one slice, because when we look at it from the coronal perspective, we can see just how upper zone predominant it is. It's starting to form scarring, and all of the mediastinal and hilar structures are pulled way up because this man now has a fibrotic process in the upper halves of his lungs. When we zoom in on it a little bit, we can now see what almost looks like asbestos plaques. They're not asbestos plaques. This is actually the nodules being dragged out and taking the lung with it. And this person, unfortunately, was significantly functionally impaired and was unable to continue working at age 29. He's also got evidence that these nodules are forming masses in the central part of the lungs, and so he has progressive massive fibrosis, undoubtedly. Here we have another unfortunate person who's 24. He's been working as a stonemason with artificial stone for 4 years. It's not very long. And he also has significant nodularity in his upper zones, starting to form nodules and masses, and also dragging the lung tissue up towards the top of the lungs, also with significant functional impairment. Now I'm going to talk a little bit about the coal mine dust disease as well, because there's a lot of overlap. So I'll go through it a little bit quicker, and then we'll talk a bit about how they all fit together. So risk factors, obviously, for coal mine dust disease include the length of exposure, how much dust was in the air, and whether you were able to use protective equipment. We're also thinking that there's probably a genetic component, because some workers get the disease and other workers from the same environment, they don't. The equivalent of silicosis in coal mine workers is called coal workers pneumoconiosis, or black lung, or CWP. And just like every other worker exposed to dust, these workers are also at risk of developing occupational asthma, emphysema, and lung cancer. CWP is a fairly slow process. Again, we have simple versus complicated CWP, very similar in concept to simple versus complicated silicosis. We know that the incidence of simple coal workers pneumoconiosis is about 5 to 10%, particularly if there is poor usage of protective equipment. We know as well that with the complicated version, there are increasing respiratory impairment symptoms, and you can continue to have development of disease even after stopping exposure to the dust. Here is a histopathological slide showing what a simple CWP lung looks like. It looks black because of the black coal macules, and so that's why it's called black lung. When we look at the chest x-ray of someone with simple CWP, it can be remarkably deceptively normal looking. And that's because the nodules can be very small and haven't started to cause any distortion. But when we look at the CT in these workers, again, we see small nodules less than 5 millimeters. They're mostly in the upper zones, like most inhalational disease. They tend to be around the bronchi, so in the central part of the lobules, and then gradually move towards the pleura. And as they do that, again, they drag the lung with it and create what looks like plaques. And each one of these nodules represents a macule of coal dust surrounded by macrophages and starting to form a granulomatous reaction. When we look at the CT for this is a fairly subtle CT, but there's lots and lots of nodules that shouldn't be there. And when I look at this case, this person has simple CWP. It doesn't mean that they're symptomatic, and it doesn't mean that it will progress, but certainly they do need to be aware of that and to moderate their dust exposures at their job. You can see here on the coronal view, again, that there's lots of nodules in the upper zones, and those little black dots all the way around the upper aspects of the lungs, that's emphysema. And again, to reiterate that dust disease itself can cause emphysema, even if the patient is not a cigarette smoker. Moving on to talking about complicated CWP or complicated black lung, very similar to complicated silicosis in principle, where these nodules start to coalesce together into irregular masses that start to drag and distort the lung around it. This can be quite an advanced disease. It can cause adjacent emphysema through traction on the lung. It causes a lot of volume loss in the upper lobes, and the prognosis for this is poor. The patient is very likely to be symptomatic by this stage of the disease. Here are some histopathological slides, again, showing that the level of blackness has gone up because of the distortion of the lungs. And this is unfortunately something that we used to see something of, and we thought we'd had eradicated. And now that we are screening for it more, we are starting to see cases of this coming back again. This is what the high-resolution CT will look like in a patient with complicated CWP. And these white greyish masses within the lungs, that's the complicated CWP, the nodules coming together and forming masses. It is extremely difficult to take a big breath in when your lungs are that scarred and distorted. You can see here on the coronal view that, again, it's really always in the upper parts of the lungs, like most inhalational diseases. And we end up with significant distortion and volume loss up there in the lung apices. So mixed mine dust disease is a really important disease for Australia. And that's because we have exposure to many different types of dust in any particular mine. We often have silicosis, as well as either coal dust disease or sometimes the heavy metal mines, heavy metal mine dust. It can be impossible to tell the difference between silicosis and mine dust, even on biopsy. Also really important to remember that asbestos exists in hard rock as well. And so even though they haven't been involved in construction or working in an asbestos factory, you can still see changes related to asbestos exposure. Emphysema is often also present, even if the worker is not a smoker. But if they are a smoker, it makes the emphysema worse. And the most common way that people with mixed mine dust disease present is with symptoms of chronic bronchitis, as well as shortness of breath. And this can be after they have left the industry, because currently there is no mandated screening for retired or former workers, either in the silica industries, the mine industries, or the construction industry. So people who've presented with those symptoms, who've had that occupational exposure, it's worth considering screening them, or investigating them, I should say, for this disease. Here is an example of a 59-year-old miner who was still working at this point. We can see that he has significant emphysema They're all the big black holes at the edges of the lungs. He also has significant nodularity throughout the lungs, and he has calcified pleural plaques, particularly well seen there over the diaphragms, to indicate that he has been exposed to asbestos as well. So here is a patient that has a constellation of findings related to his occupational dust exposure. Now, I wanted to go through as well a little bit about how things have changed from the regulation and legislation perspective across Australia in the last 4 or 5 years. There's a couple of documents that I've put up here which I think are really, really beneficial to read if you have any further interest in this area. And the first one is put out by the Royal Australian and New Zealand College of Radiologists in 2019. And it was really a guide to the imaging of occupational lung disease, focusing on silicosis and pneumoconiosis. And that's formed the basis for many of the subsequent decisions that have been made about appropriate imaging. We also have the National Guidance for Doctors that was released by the National Dust Disease Task Force a couple of years ago, which is about how to assess workers exposed to respirable crystalline silica. And that's an excellent resource for anyone, particularly GPs, who may be seeing patients which give an appropriate history and raise the concern for silicosis. There has been in the last 5 or 6 years an increased requirement to report some of the imaging to different classification standards. And for the chest X-ray, which remains the workhorse for radiological assessment of these workers, we use the ILO classification, the International Labour Organization. Now, the ILO classification form, which is a PDF form that's there, is provided, but as with every other radiological report which is given out across Australia, you will receive it in the normal format that you would receive any other radiological report. Now, I'd like to ask another poll question to see what people think about a B-reader radiologist and what that means. So I'll give you again about 15 to 20 seconds to choose an answer under the poll manager. What is a B-reader radiologist? Is it A, a radiologist that is not accredited as highly as an A reader? Give you a clue, I'm a B reader, not an A reader. Answer B, a radiologist that only reports breast imaging. Give you another clue, I don't report any breast imaging and I'm a B reader. Option C, a radiologist accredited to report to ILO standards. Or D, all of the above. I'll give you another few seconds to answer that one. And to everyone's shock and horror, it's C, a radiologist accredited to report to ILO standards. So let's talk about why we would want to put a classification system across the chest X-ray. The advantages of doing that means that you get a standardized report and that it is reproducible across different people who would be looking at the same X-ray. It means that you have to look at all of the different parts of the X-ray that could be showing changes related to occupational lung disease. And the people who have been accredited as B readers must have been trained in how to do that and shown expertise in it by passing an exam. There are disadvantages of using a classification system though, and the first and most important one is that early changes of silicosis and other types of pneumoconiosis may not show on the X-ray. So having a normal or a negative ILO result can be falsely reassuring. And we know that in workers who present particularly with the fluffy changes in the acute or accelerated silicosis, the chest X-ray is not very sensitive at picking up those abnormalities. It is more time consuming to fill in these forms, and it is more costly for that reason. And most radiologists haven't had the training in this. And so it means that it's not something that every radiologist across the country is able to do. I guess the silver lining of that, though, is that we have, groups of radiologists across the country who do a lot of this work and get quite good at it. So we have another poll question. Again, you'll have about 15 or 20 seconds to fill in an answer under the poll manager. What is the advantage of ILO radiology reporting? Is it A, standardized and reproducible reports? Is it B, assessment for all recognized changes in occupational lung disease? Is it C, B readers have training and expertise in this area? Or D, all of the above? And of course, the answer is D, all of the above. I do want to talk a little bit about when you would choose a chest X-ray over a CT. So chest X-ray obviously is a very commonly performed imaging modality around the world, and it is used to screen for occupational lung disease in most places that have screening programs. It is, however, poorly sensitive, as I've already said, for the early changes of occupational lung disease, and it's very poorly sensitive to look for changes like respiratory bronchiolitis, chronic bronchitis, or emphysema. Now, CT, on the other hand, is more sensitive, but it is less available in some places. It does take more resources to do and report a CT. It does come at a slightly greater cost, and there is an increased radiation dose compared to an X-ray. However, there are certain things that have happened technologically in the last 10 years which mean that the radiation dose for a CT of the chest, where we don't give contrast, like we would do for this sort of case, has really come down. It's probably a fifth of what it was 10 years ago. And there's quite a few scanners out there now which give as much radiation as, 2 or 3 chest X-ray series. So really, we're talking about a very small radiation dose. And there's a lot more availability of CT than there used to be 10 to 15 years ago. We know that there are still limitations in access to CT in some of the regional and remote areas around Australia, where a lot of these workers work and live. And there's certainly a high focus from state and federal government level to increase the availability of those scanners to those workers. So I'll show you some scary examples of patients who've had normal-looking chest X-rays, which even in retrospect are completely normal. And then you go ahead and look at the CT and you realise that there's quite significant nodularity. This is clearly a case of silicosis, or in this case, co-workers pneumoconiosis, and there's also emphysema. So this worker has significant disease and needs to be counselled about, the risk of progression if they continue to work in the industry. The chest X-ray is completely normal. Here is another example of a completely normal chest X-ray with a CT done because the patient presented with symptoms showing significant nodularity throughout the lungs, and this person also has simple pneumoconiosis. Here is an example of somebody who has presented with acute silicosis. So again, just to remind ourselves, that is a short but intense period of dust exposure of less than 3 years. We know that people who are identified in the acute silicosis stage are easier to treat. They have a better prognosis if they stop the exposure to the dust, and they may not progress to even having any fixed nodules at all. This patient had a completely normal chest X-ray, even in retrospect. So again, cases of this are not uncommon. We know that about 40 to 45% of cases where we have proven CT changes, their initial chest X-ray was normal. Now, I wanted to go through for the next 5 or so minutes, just talking a little bit about the extent of the problem. And I'll use Queensland as the use case because that's where I am and that's where we have most of the information. We understand from the engineered stone screening cohort that started back in about 2018. And as of a couple of years ago, there were over 230 accepted claims for silicosis, which was 22% of that initial cohort that underwent the mandatory screening program over that 2.5-year period. 32 workers had PMF. And none of these workers had been screened before or presented for imaging or investigation. Most of them were asymptomatic, and 43% of the ones that were CT positive cases in the largest cohort that we have available to date had a normal chest x-ray, which was distressing because, of course, the next thing you think about is, well, how many people just had a chest x-ray and didn't go ahead to have a CT? And for that reason, we now have a new protocol in place for these workers, where if you are a high-risk worker, based on the level and extent of exposure, instead of having chest x-rays for surveillance, you will have a low radiation dose CT scan instead. Now, if we have a look at the most recent information released by the Resources Health, Safety and Health Queensland Department about all dust diseases, we can see that the most, the most common claim that is made for compensation, at least, remains at mesothelioma. So we can't forget that. But we also have an increasing number of people that are making claims for silicosis, for mixed dust disease, chronic bronchitis or emphysema. And there was about 270 claims that were made in the 2021 to 2022 year. Now, how does that compare across age groups? Well, unsurprisingly, most of the patients will be age 60 and above. And that again reflects the longevity in the industry, that they've been exposed to dust for a longer period of time. It is obviously worth noting that these are just people who have made claims for compensation. It doesn't reflect the full extent of the problem, but it does reflect, I think, the distribution of disease. We are starting, however, to see an increasing number of workers in the very young age groups, 20 to 39, 7%, and then 15% workers between 40 and 59. So when we talk about these new claims in that financial year, what type of dust were they exposed to? Again, asbestos remains at the top of the list in terms of the prevalence. And then there's a big drop off, and then we get silica exposure and we get coal exposure. When we talk about the primary industry, again, reflecting the asbestos exposure, construction is the most common industry. So don't forget your construction workers, followed by manufacturing, and then mining, resources and quarrying, and a mix of other industries combined. So how has it really changed? Is it changing over year by year in terms of what people are making claims about? Well, there's no real change really since about 2019, which is perhaps somewhat reassuring, but it also tells us that there's many more people being diagnosed that haven't yet made the claims that may come in the next 1 to 2 years. However, if you look at all of the claims that were made prior to 2019, going back into the last century, there was only a total of 491. And so really, that year of 2019 to 2020, once it became, more, I guess, aware across the industry, and we started actually looking for disease, we started finding many more cases of disease. And we can see here that there is a large increase in the number of cases diagnosed in coal. It looks like this reassuring drop-off at the end, but that was an incomplete year of data. So it actually went up even further at the end for that one. When we talk about MMQ, we're talking about mineral mine and quarrying, which is more of a silicosis disease. And that number in the purple line is going up as well, which is mixed coal and silica. And the silica on its own is the orange line. That line started to go up a couple of years ago, and that reflects the fact that surveillance for silica workers lagged behind the coal workers by 2 years. I expect to see that number will continue to go up further. So just briefly around the rest of the country, the Victorian WorkSafe program was also very active early on. They had a similar rate of workers who were exposed to the artificial stone, 25% of their cohort at their at their release of data 2 years ago, had been diagnosed with silicosis, including 42 of them with complicated silicosis, which is a shocking percentage. And very similar, 28% of workers who had silicosis on the CT had a negative chest X-ray. So again, it's a significant proportion of these cases had a negative X-ray to start with. In New South Wales, they've also been publishing some data about their results. They had just about 1,500 workers over the course of a calendar year and over 100 cases of silicosis. They were basing their diagnosis on spirometry and X-ray, and recently there have been moves in New South Wales to increase the availability of CT diagnosis using the low radiation dose methods to make sure that the investigation is done with a more sensitive threshold for disease. Western Australia had been screening all of their silica-exposed workers with chest X-ray, hadn't had any positive cases by the end of 2019. They did a project in 2020 where they offered 100 stone workers with at least 5 years of exposure in the engineered stone industry a low-dose CT. 90 of those workers agreed, and 8 of them had features of silicosis. And that prompted a change to the legislation in Western Australia, where now the engineered stone workers undergo a two-yearly low-dose CT, and other silica-exposed workers a 5-yearly low-dose CT. Here's a nice summary slide, which is part of that final report by the National Dust Disease Task Force, which is, again, a great document for anyone who's got greater interest in reviewing this, including a wonderful, I think it's a 3 or 4 page summary at the start of the document, which is very readable and gives very good and clear guidance, demonstrating that, once mandatory screening started to occur, there was a significant rate of disease in workers exposed to the artificial stone. Now, just to wrap up what I'm going to say before we head into some question time, what would we like you to be writing on the referrals? If you have patients that have come in and they have an exposure history to dust, please write it on the referral if you're asking for a chest X-ray or a CT. And particularly if they've been exposed to silica, if they've been exposed to mine dust, particularly coal, and if they've had an asbestos exposure history. It's also very helpful to us to know whether they are a current or an ex-smoker, or whether they are a never smoker. If you know the pack years, it's helpful to know that, just as a guide for how much smoking-related change we might expect to see from smoking. Obviously, if there's symptoms, please write that down. If you have information about spirometry or whether there's a previous result somewhere else, that's very helpful. It's also very helpful to know whether you would like it reported as an ILO format, because it does across pretty much every radiology provider across the country. That would prompt a different pathway to get read by someone who's ILO qualified. And here's the final poll question. Again, you'll have about 15 seconds to answer this one. GPs should be aware that the at-risk patients may not be part of an occupational lung disease screening program if they have left the industry, if they are casual workers, or work in an industry that does not have mandated screening. Is that true or is that false? And the answer, of course, is that it is true. A lot of these workers will not be undergoing mandatory screening through their workplace and may present to their GPs. Let's just wrap up with what's going to happen in the future and how are we researching the best way forward. We have currently a program, research program in Victoria that's looking at engineered stone workers, analysing the CT versus the chest X-ray results, and that is underway through my team at Monash, and we shall be publishing on that in the next few months. We also have a research study underway in Queensland, funded by the Queensland State Government, which is looking at chest X-ray versus CT done in Queensland coal and natural stone workers, not looking at engineered stone because it's already being evaluated in Victoria. We have a project underway in Western Australia that's looking at the ultra-low dose CT versus regular CT in silica-exposed workers to see how low we can go with radiation. And the aim of all of the research, of course, is to guide any iterations in CT screening legislation, particularly in our high-risk populations, to make sure that they are appropriately looked after. And there's an increasing focus on using machine learning and other AI techniques to aid the interpretation of chest X-rays and CTs to predict either current occupational lung disease or the risk of developing it in the future. And that was it. So that was my presentation. I hope that we have questions. Phil, do we have any questions from the audience?
Yeah, thanks, Catherine, for such a comprehensive presentation. We definitely do have questions from our active participants. The first group of questions relate to the imaging choice. Several questions have asked, is there any point in organising a chest X-ray at all? And if you are going to organise a CT, should you be organising a high-resolution CT or just specifying a CT?
Great question. So in terms of should we still be doing the chest X-ray, the answer for most people is yes, particularly if there is, you're not sure if this is going to be silicosis, and there's always some, of course, diagnostic uncertainty before we investigate fully. So chest X-ray is a great starting point. It looks for other things as well, heart failure, as many, many things. In terms of what we should be writing on the form, that radiology document from 2019 spelled it out very clearly. We should be asking for a high-resolution CT, and we should be asking for an inspiratory and an expiratory phase. Now, if you send it to a company like IMED and you say that it's for occupational dust exposure, we know exactly what we're doing and everyone will get the right test. And it will come through to a central team of chest radiologists who are experienced in occupational lung disease, and we will take it from there for the reporting. Of course, you want to be giving as much information as possible from your side so that the radiology provider, can make the appropriate decision. So HRCT, absolutely, and make sure that you say it's for occupational dust disease evaluation.
Thanks. Gersel asks, could a tiler get silicosis? Because they're cutting tiles too, and if so, would they develop immunological markers suggestive of scleroderma?
Yeah, so again, two great questions there. Absolutely, tilers, carpenters, electricians, plumbers. We've had people from all of those industries present with positive diagnoses of silicosis in the last few years. All of those people should be eligible for screening, but it does vary state to state. And unless you are one of the designated industries that has mandated screening, you may not find that these workers present. A lot of them are self-employed as well. And so, there's another barrier to people coming forward for screening. But yes, absolutely all of those industries, as well as anyone working as a general construction worker. Now, in terms of the question about demonstrating markers for scleroderma, it has been postulated before, and in fact, it is one of the suggestions, not a recommendation, but a suggestion in that National Dust Disease Task Force document, that assessing people for connective tissue disorders, looking for ANCA and various other markers in the blood could be very helpful, and quite a few of these patients end up having rheumatological review because there is such a high risk of or high rate of association with things like lupus and scleroderma and rheumatoid. In fact, we've got a number of people who have presented via their rheumatologist who has then said, I think maybe we should get your lungs evaluated as well.
Thank you. Now, Rani asks, why is there such a difference in screening imaging for silicosis guidelines, for instance, Western Australia compared to Queensland?
Excellent question as well. So one of the recommendations from the National Dust Disease Task Force was that we should have a uniform policy around every state. One, for equity, to make sure that people get the same level of care, but also because people move from state to state and there's no consistency right now in what we do. I'm happy to say that Queensland, New South Wales and Victoria are almost completely aligned now in what we offer and what we recommend, and that is very much based on a risk assessment, whether you're low risk versus high risk in terms of your dust exposure history. Western Australia did move towards 5-yearly CT scans, which was a little bit out of sync with the rest of the country. However, they had experts in their jurisdiction making that recommendation. But we are moving certainly towards a national, Safe Work Australia endorsed recommendation that would cover all the states of Australia. And we are also moving towards a national dust disease registry so that we can track when these diagnoses are made. We're not relying then on information that comes from accepted compensation claims.
Thanks. Now, Andrew asks, do farm workers, especially those who plough and crop, get these lung conditions?
Well, they get a whole heap of other things called farmer's lung. So I think the take home for me is that no matter what you do for work, you're going to get something as an occupational hazard. There's many inhalational diseases out there. In fact, if you Wikipedia it, I think there's probably about 50 or 60 of them. We tend to find that people who work in agriculture are a bit like people who work in construction in that they have a mixed exposure history. So they get the hay-related dust, they get the welding fumes, they get the diesel particulates, and they may have done some concreting. There's actually a mix of diseases. And farmers are more likely to get hypersensitivity pneumonitis, like many other workers. But it comes down again to what the individual occupational history is like and what they've been exposed to.
Now, Moen asks, is there any guidance as to what would fit the definition of a high-risk worker in the industry? You mentioned before welding dust, particularly about that. Is that a significant risk?
Yeah, so in terms of what's considered to be high risk, the Queensland government took this out to consultation across the mining industry, and the mining industry came back and said, we actually don't consider anyone to be low risk in our industry, because they can't control how much dust there is out there, which I thought was probably a very conservative but reasonable approach to take. We know that occupational hygienists are often visiting these sites, whether they be mine sites or other sites, and over time, the concentrations of dust and particulates in the breathing atmosphere have gone down. Over time as well, what has been considered to be legal and an acceptable level of dust continues to drop. For example, it's dropped in Australia by more than in Queensland by more than 60% for the concentration of coal dust that's considered to be okay. And over time, of course, this means that the workers will be exposed to lower concentrations of dust on the whole. In terms of the welding fume question, we have we've actually got through the Lung Foundation Australia an occupational lung disease research network, and this is one of the exact questions that we have on our agenda, is to work out where the next lurking catastrophe could be coming from, and welding fumes is definitely one of the ones on our radar to investigate further. The literature out there suggests that welders do get significant lung disease as a result of exposure to fumes. Diesel particulates, there's so many industries out there that have their own unique occupational hazards.
Now, Stephanie asks, are we seeing any changes in chest x-ray that are COVID related? Are these impacting ability to read the chest x-ray properly?
In a word, no. I think we are starting to see some people coming through with COVID-related changes that haven't resolved after the initial acute inflammation related to COVID. But the long COVID changes really don't significantly overlap what we're seeing with occupational lung disease. So from that perspective, I'm not particularly concerned.
Thanks. And James asks, is there an anatomical or histological or other reason that the upper lungs are more likely to be affected in inhalational lung diseases?
This is probably the sort of thing I used to know when I was a medical student, but the general feeling about it is that anything that's inhaled is more likely to be inhaled upwards. It's the same with cigarette smoking. We see the changes of emphysema more likely in the upper zones. I suspect there's also something to do with the perfusion of the lungs being greater in the bases and more likely to be able to absorb any of the inhaled particles. It also has a better lymphatic drainage in the bases where we don't have that as much in the upper zones. And so when you're unable to either resorb or expel the dust particles, you're more likely to have to try to wall it off in a fibrosing nodule. And I think that's pretty much the reason why. It's the same with TB, like TB's up there as well. And there's actually an entity called Silicotuberculosis, which we haven't seen a great deal of in Australia, although we have in some of the more remote areas, because again, TB is more likely to infect your upper zones, and that's where you're most likely to get the pneumoconiosis. And there's a really high association of the two together.
Thanks very much. I think, Catherine, we've probably run out of time for the rest of the questions. We do have a few others. So what will IMED will try and do for those participants that have asked questions that have not been answered, we'll try and get Catherine to have a look at them and answer them in time on the IMED website so that it can be followed through. Thanks, Catherine, for such an informative and helpful presentation that's really relevant to us all. I'll just swap back now to Sue to sign off. Thank you.
Thanks, Phil. In conclusion, I'd just like to express my gratitude as well to Professor Jones for her insightful presentation and Dr. Pearlstein for his experienced facilitation tonight. Also extend my thanks to our audience for joining us. We eagerly await your feedback, so please stay online as you will be soon redirected to complete your evaluation. Stay safe, stay well, and have a great night.